Good day, year two students. This is Dr. Marwan again with you for the pharmacology lecture of the reproductive system. We're talking about the uterotonics and tocolytics, or drugs that can accelerate labor or causes stimulation of contraction of the pregnant uterus, or drugs that decelerates or breaks pushes the brake for the progression of labor, or what we call tocolytic agents. So this is an introduction about the shape of the uterus and this myometrium and the site of the pacemaker up in the fundus of the uterus. We know that uterine contractions play a critical role in menstruation, pregnancy, and in labor or parturition. Now, the activity of uterine smooth muscles is tightly regulated by hormones and by pharmacological agents. The hormones are mainly the estrogen and the progestin or progesterone. Estrogen is considered as a hormone that causes contraction, and progestin is considered as a hormone that causes relaxations. Now, drugs that affect the uterus are broadly classified into those that can stimulate the contraction or uterotonics, and those drugs that can relax the uterus, which are called as tocolytic agents. Now, in the early times of pregnancy, the high level of estrogen causes hyperpolarization of the myometrium, and the outcome for this hyperpolarization is that the suppression of any spontaneous contractions. While towards the end of pregnancy, uh, the same estrogen hormone over the long term, towards the end of pregnancy, the uterine myometrium will be exposed for a long term, and this causes upregulation of the oxytocin receptors. And the outcome for that is that the contraction will start to increase in force and frequency, means in amplitude and in frequency, becoming fully coordinated, ready for the delivery of the fetus by the start of uh, widening or opening of the cervix. The important receptor distribution over the myometrial smooth muscles, if we consider this one is one of the enlarged or enlarged view or zoomed in smooth muscle of the myometrium, we can find some at least 5 major types of receptors that are involved in myometrial contraction and relaxation. First, we have the alpha adrenergic receptors. Alpha adrenergic receptors that is supplied usually by the noradrenaline that is released from the terminal sympathetic ending. Then we have the oxytocin receptors, which binds directly to oxytocin hormone. The prostaglandin receptors, which are important for the widening or ripening, opening of the cervix during the first stage of labor, namely prostaglandin E1 receptors, prostaglandin E2, and prostaglandin F2 alpha. And last is 5-hydroxytryptamine, which is serotonin receptors. All these are considered as stimulant receptors, uterotonic receptors. The activation of these receptors will stimulate uterine contraction. This is in contrast to the beta-2 receptors, which is also cell membrane receptors on the smooth muscle of the myometrium, which when stimulated, it can lead to uterine relaxation. Now, the clinical takeaway message is that the autonomic nervous system provide opposing contradicting inputs. Noradrenaline drives contraction, as we said, through alpha receptors, while adrenaline through beta 2 receptors. Adrenaline circulates in the blood by being secreted after being secreted from the adrenal medulla, and binding to beta 2 receptors will lead to relaxation of the smooth muscles and therefore prevention of preterm labor. About the uterotonics or uterine stimulants, we start with oxytocin, which is the inducer. It is the natural inducer of all kinds of natural labors. The source is synthetic preparation of natural hormones, usually given by intravenous drip. It can be given intramuscularly too, but the best route of administration is intravenous drip slowly. And the primary objective of treating with oxytocin is to induce labor, to shorten the first stage of labor, usually long, especially in primea gravida, and in the management of third stage of labor during the delivery of the placenta. However, the limitation of the use of oxytocin is that it's ineffective for expelling uterine contents in early or mid-pregnancy because the uterine smooth muscles are not yet upregulated with the oxytocin receptors. So even if you give oxytocin during early pregnancy, there is no enough oxytocin receptors upregulated by the effect of long-term estrogen exposure, which needs the uterus to reach the third trimester in order to achieve that response. For the prostaglandin, usually they are synthetically prepared. Prostaglandin E1, E2, and F2 alpha, which are types of under the class of eicosanoids. Primary objective is early and mid-pregnancy abortion if there is an intrauterine fetal death in early or mid-pregnancy. It can help the abortion by the use of prostaglandins analogs, and in late pregnancy it can lead to cervical ripening, means opening, starting dilatation of the cervix. But the unique trait is that it causes simultaneous contraction of the body of the uterus. At the same time, it relaxes the cervix. So this makes it important because it can stimulate the expulsion of uterine contents correctly. For ergometrine, which is usually derived from ergot fungus, the primary objective of using it is to prevent and treat postpartum hemorrhage after the delivery of the placenta, but it is only effective on the relaxed uterus. It does not affect usually the contracted uterus, and it leads to sustained continuous type of contraction, in contrast to oxytocin, which leads to rhythmic intermittent type of contraction. As we said, oxytocin is usually administered intravenously by intravenous infusion, but it can be also given intramuscularly. It is rapidly inactivated by the liver, kidney, and circulating placental oxytocinase enzyme. Now, it is naturally released by the posterior pituitary, and the natural stimulants is cervical dilatation and suckling also of the female nipples by the baby also. The severe side effects can be hypertensive crisis, water retention, water intoxication, because it has an antidiuretic hormone-like effect and pressure effect, but lower than that of vasopressin or antidiuretic hormone. It can lead to uterine rupture in case of fetal malpresentation, or even fetal obstructed labor and fetal death. Now, the absolute contraindication, therefore, is a premature birth, fetal distress, and abnormal fetal presentation. Ergometrine, on the other hand, it is derived from the ergot fungus, as we mentioned before, and it causes sustained continuous contraction of the relaxed human uterus, which leads to reduction of placental bed bleeding. Therefore, it prevents used for the prevention and treatment of postpartum hemorrhage. The action is by stimulation of alpha and 5-hydroxytryptamine serotonin receptors. The onset is fast and it lasts for up to 6 hours. However, there are some systemic side effects, which includes nausea and vomiting from stimulation of dopamine D2 receptors at the chemoreceptor trigger zone. So it leads to nausea and vomiting. It causes moderate systemic vasoconstriction, which raises the risk of increasing blood pressure, headache, and blurring of vision. The coronary vasospasm or vasoconstriction can lead to angina pectoris as a risky side effect. Now, both synthetic oxytocin and ergometrine, they can be given either separately or can be given combinedly in one vial, in one preparation, one synthetic preparation. We call it symptometrin. So the idea is to have immediate and rapid onset of rhythmic contractions by oxytocin, which facilitates makes the first stage of labor rapid until the expulsion of the placenta, while for ergometrine it causes sustained type of contraction lasting for up to 6 hours, and it acts as a clamp to clamp down the placental bed, preventing any bleeding postpartum hemorrhage. So the combination of both is called symptometrin. As for prostaglandin analogs, we previously mentioned that they have dual kind of mechanism of action. The first is that they cause relaxation or start widening or dilatation of the cervix. At the same time, it causes contraction of the body of the uterus. So by this expulsion of the uterine contents, because of the dilatation of the cervix and contraction of the body of the uterus, all the contents can be expelled. The three commonest types of prostaglandin analogs is misoprostol, which is a prostaglandin E1 analog, can be administered intravaginally as vaginal tablets, and it's combined with mifepristone, which is a progestogen antagonist that sensitizes the uterus. And this can, with the use of mifepristone, we can lower down the dose of misoprostol and minimize the side effects in the beginning of pregnancy. This can be used for cases of incomplete abortion or missed abortion. Dinoprostone, which is a prostaglandin E2 analog, can be given as vaginal gel tablets or can be injected intraamniotically. But the warning, in case of intraamniotic injection, it causes abortion, but if the intraamniotic fluid escapes into the circulation as a result of an injection invasive method, then this can lead to cardiovascular collapse to the mother and the fetus. For carboprost, it is a prostaglandin F2 alpha, can be given by deep intramuscular injection for the treatment of severe postpartum hemorrhage. The adverse effects is uterine pain, abdominal pain, nausea, vomiting, and diarrhea in about 50% of patients, phlebitis, inflammation at the site of the injection if given by intravenous infusion. Now, in contrast to the uterotonics agents or uterine stimulants, the tocolytics or uterine relaxants are used to delay the labor and not to accelerate. That's why they call it the brakes. So if you want to push the brakes for the labor to start, we use tocolytic agents. If we want the labor to start faster, we use the accelerant or the accelerators of labor, or use what you call uterine stimulants or induction of labor by the drugs that we have mentioned in part 1. In this part 2, we talk about tocolytic agents or uterine relaxants. Uh, they are used actually to stop premature uterine contractions that can lead to preterm labor. Preterm labor is going to be associated with a great risk to the fetus because the organogenesis is not yet complete, and therefore especially the lungs and the nervous system. So any preterm premature uterine contractions between the pregnancy time 22nd until the 33rd week of pregnancy, tocolytic administration should be um, advocated. And the objective is to stop uterine contraction and stop labor. But this cannot be continued for long time. Usually the window for delaying labor, for premature labor, is only for 2 days, 48 hours. This is the window where we can administer glucocorticoid therapy to the mother in order to speed up or accelerate the maturation of the lung through the maturation of the surfactant of the lung, which helps the baby lung to recoil and to reduce the distress, the respiratory distress syndrome that can happen upon delivery. So this is the goal, the therapeutic objective, to protect the fetus. We use glucocorticoids for fetal maturation of the lung, reducing the neonatal respiratory distress. In addition to that, um, magnesium sulfate can be given also intravenously to as a mediator for fetoneuronal protection, especially from cerebral palsy upon delivery as a premature delivery. Yes. So as we can see that after we give a tocolytic agent, the efficacy of myometrial responsiveness, or the efficacy of the tocolytic agent, starts to diminish. That's why we use it only for this window of 48 hours or 2 days. In addition, furthermore, there is a higher risk after 48 hours that on the mother. Specifically, there can be a life-threatening pulmonary edema that can spike exponentially. The risk will increase exponentially after 48 hours, especially for those females treated with beta receptor stimulants, salbutamol, or other tocolytic agents. The major 5 classes of tocolytic agents and their mechanisms of action is the number 1, beta-2, selective beta-2 agonist, ritodrain, and salbutamol, widely used because they stimulate beta-2 receptors on the lung, but also they stimulate beta-2 receptors on the pregnant uterus, and this will decrease intracellular calcium, decreasing phosphorylation myosin light chain kinase, and therefore causing uterine relaxation. On the other hand, the antihypertensive agent nifedipine can be also used because it has a direct blocking effect to calcium transport across the cell membrane, leading to uterine relaxation. And this has a specific beneficial effect if the preterm labor is associated with pregnancy-induced hypertension in the pregnant lady. We know that pregnancy-induced hypertension can lead to put the female under the risk of preeclamptic toxemia, and then therefore nifedipine can be used both as a tocolytic agent as well as of benefiting the control of the increase in blood pressure or hypertension, treatment of hypertension. Magnesium sulfate is the third one that can be given because it's a divalent cation, positively charged. It competes with calcium also for the cell membrane intracellular and intracellular receptor binding, and therefore it is considered to have a moderate, low to moderate tocolytic uterine relaxant activity. The cyclooxygenase inhibitor indomethacin can block the synthesis of endogenous prostaglandin, therefore can inhibit the ripening or the dilatation of the cervix and inhibit the contraction of the body of the uterus, as we said, by inhibition of these the prostaglandin E2 and prostaglandin F2 alpha. Oxytocin receptor has an analog, has an antagonist, which is atosiban. Atosiban is a competitive antagonist that directly blocks the oxytocin receptor, leading to uterine relaxation. So these are the 5 major classes and the example for each one of them and their clinical uses. Now, the adverse effect and the contraindications for beta agonists. It can lead to tachycardia, palpitation, flushing, and pulmonary edema if used for more than 48 hours, continue to be used for more than 48 hours during pregnancy that has a gestational age of more than 22 weeks until 33. The contraindications is cardiac disease, conditions where tachycardia masks the bleeding. For magnesium sulfate, as we said, it interferes with calcium receptors. Adverse effect is skeletal muscle relaxation, absent deep tendon reflexes, respiratory depression, and cardiac arrest. And the contraindication is severe muscle weakness, as in cases of myasthenia gravis, because it can aggravate the original existing condition. For calcium channel blockers, we said that nifedipine, it blocks calcium channels directly, but the side effect can be from vasodilation, hypotension causing headache, reflex tachycardia, flushing, and therefore it's contraindicated in hypotensive females, but it is highly recommended if there is a pregnancy-induced hypertension associated with preterm or premature uterine contraction. The Philippine can act on both conditions in this pregnant lady. Non-steroidal anti-inflammatory drug indomethacin will block the synthesis of prostaglandin synthesis, but it can lead to adverse effect of maternal bleeding, fetal on the fetus. It can lead to premature closure of ductus arteriosus and decrease fetal renal function. For oxytocin receptor antagonist, which is atosiban, it has a minimal actually side effect, and the contraindication is not really much about it. The safety advantage of atosiban as an oxytocin receptor antagonist, reversible direct antagonist to the oxytocin receptor, is that it has a very low systemic side effect, very mild, limited to vasodilation, nausea, vomiting, and hyperglycemia. It has zero fetal toxicity, completely avoided the severe fetal risk of non-steroidal anti-inflammatory drugs like ductus arteriosus, renal failure. It's zero fetal toxicity, zero cardiopulmonary toxicity, which can prevent or can avoid the incidence of pulmonary edema and cardiac arrest, which is the risk that is associated with the use of beta-2 agonist and magnesium sulfate. So, as a summary for the lecture topic, we say that the agents can be used in early or mid-pregnancy to terminate pregnancy are the prostaglandin, especially misoprostol, mifepristone. Why? Because they are able to cause dilatation of the cervix and contraction of the fundus of the uterus, so expelling the contents before the oxytocin receptors are upregulated. So at this level, before the upregulation, oxytocin and other hormones are ineffective to terminate pregnancy, especially in cases of incomplete abortion, missed abortion, or intrauterine fetal death at early trimester. For the induction of labor at term, of course, we use symptometrin, which is a combination of oxytocin and ergometrin. And the first one oxytocin causes rhythmic contraction of the pregnant uterus, while ergometrin causes sustained continuous contraction of the relaxed uterus. So the first one will help the first and second stage of pregnancy. The third one will help to treat and prevent postpartum hemorrhage by its sustained continuous contraction. Why do we induce labor? The use of oxytocin replicates the natural physiological trigger to facilitate or to accelerate the first and second stage of labor until the delivery of the placenta, the third stage, and ending up with blocking the blood flow through prevention of postpartum hemorrhage using ergometrin. For premature uterine contraction that can lead to preterm labor and the risk of fetal maturation or immaturation of fetal organs, so we use breakers. We try to pull the brakes, or by uterine relaxant, tocolytic agents, atosiban, nifedipine, Ritodrain, but there is a therapeutic window of 48 hours for glucocorticoids to be given to the lady intramuscularly, so that these glucocorticoids reaches the lung of the growing fetus and facilitates or accelerates the maturation of the lung surfactant, so that the newborn premature infant or premature newborn can have less or lower risk of having fetal respiratory distress. For the treatment of postpartum hemorrhage, as we said, we can use symptometrin, the combination, or carboprost as a prostaglandin F2 alpha analog. It causes rapid, sustained clamping of the relaxed placental bed by the use of ergometry. So if you have reached this level of the last slide, you must have had a hint or a clue about one of the important single-based answer questions that's going to appear at your end of semester exam. With that, thank you very much and see you in another lecture.